My name is Pablo Maroto. I'm a medical oncologist working in Barcelona. I work in a university hospital. I've been involved in clinical trials and in the management of patients with GU cancer for the last 25 years. So, in fact, GU cancer has nothing to do with the GU cancer I had in the 25 years ago. I've seen the development of the new therapies for prostate cancer first. Then I've seen the development of new therapies for kidney cancer. And I'm very lucky as I think a new panorama, a new number of new therapies for urinary tumors, for urothelial tumors. An important point here, we have the GU cancer means hormonal therapies if we treat patients with prostate cancer, if we treat patients with kidney cancer, targeted therapies and immunotherapy, and with bladder cancer we have a little bit of everything, a little bit of chemo, a little bit of ADCs and immunotherapy. So yeah, I think it's quite a nice area, and we see a lot of clinical research for patients with urinary tumors. That's something I love. Let's start with bladder cancer. We have seen the new data in the recent years. So for bladder cancer, we have moved from chemotherapy as the standard of care to ADCs. ADCs means antibody-drug conjugates, a new type of therapies to deliver directly to the tumor cell, the tumor, an anti-tumor charge that can be an isotope or can be a chemotherapy. So it's a complete new setting of therapies, and we have moving from cisplatin-based chemotherapy in the future to ADCs. Considering prostate cancer, we have three areas of interest. First, the androgen receptor, and we have a new data, new drugs targeting the androgen receptor. That is the most important point or the most important driver in prostate cancer. Second, we've seen the possibility of targeted therapies being used in bladder cancer with the arrival of PARP inhibitors to the treatment of prostate cancer. And finally, the radioisotopes, the ADCs with Pluvicto as the best example, a new line of therapies targeting the PSMA, that is a new target in prostate cancer. And finally, kidney cancer. Kidney cancer, we've seen the possibility even of cure of some patients with metastatic disease using combinations of immunotherapy. So that's a new paradigm in kidney cancer. Yes, well, in general, I am a medical oncologist, so I've been talking about systemic therapies, but the first and very first improvement, it's been the surgery techniques. The use of robotic surgery and the Da Vinci technique or technology has shortened the hospitalization of these patients, has limited the side effects of the surgeries, and not only that, we can treat surgically more patients than time before because these techniques are easier and better tolerated to the patients. So yeah, it's absolutely local therapies have changed, and surgery absolutely have changed, not only for patients with bladder cancer, also for patients with prostate cancer. The surgeries are not the same. In the old times, to give you an idea, patients with a prostate cancer may have to stay in the hospital for 3 weeks or more. Right now, they are at home just after 1 week or less. In the kidney cancer, the arrival of the anti-angiogenic therapy was a breakthrough. The old times we only had interferon, interleukin, and we are talking 20 years ago. And the next move in kidney cancer was the immunotherapy. The combinations of PD-1 and CTLA-4 can provide long-term survivals, and that's a breakthrough. So we have changed totally the first-line therapy for kidney cancer. In bladder cancer, as I said, the introduction of ADCs has represented a complete change in the management of this disease, moving from chemotherapy to new therapies, not only because efficacy is higher, toxicity is lower. I think both are equally important. And finally, in the prostate cancer, in the old times, we only had those ADTs, some drugs reducing the level of testosterone. Now we have drugs targeting the androgen receptor that have shown a benefit in overall survival for years for some patients, and with a quite convenient toxicity profile. So it's I cannot say yet that we are transforming the cancer in a chronic disease, but at least we have improved a lot the long-term survival of this patient. So the main challenge at this moment for in the oncology field is the individualization of therapy. All trials treat all patients to benefit some of them, but not all, and exposing all the patients to toxicity. So I think to improve data and to improve results, we should select those patients that can benefit most from the therapies, not only in the metastatic setting, also in the neoadjuvant or early stages of the disease. So a big challenge for it is not only because you can save toxicity for some patients and improve results, you can also save money because if you treat the proper patients, you are saving money, saving toxicities. So I think it's the main challenge for the future. Yeah, absolutely. For example, in bladder cancer, we always first results with immunotherapy with checkpoint inhibitors quite poor. The response rate was not quite good. Combination with chemo did not provide successful results, and we have some examples in urothelial cancer, for example, with atezo plus chemo, emro plus chemo, a lot of negative trials. But in the end, when you combine the right checkpoint inhibitor with the right drug, as M42 Pembro, that is the standard of care right now as first line, or when you use immunotherapy in the right place, for example, maintenance therapy with avelumab, that was a very successful trial, you obtain positive results for those patients. So if you try to use the drug in the wrong area or in the wrong clinical situation, you may expect poor results. But when you use the right drug in the right situation, you can get still, with the same drug, good results. So the example, as I said, you combine a PD-1 inhibitor plus chemo in first line, results were negative, but you use the PD-1 inhibitor as a maintenance and the results of the trial were positive. And I wouldn't expect those results positive considering the combination trial. So it's more complex than we thought. It has its own challenges. For example, for prostate cancer, we know that they can provide very long-term responses and long-term survivals for these patients. So one of the misconceptions, if you have a metastatic disease, you think that my prognostic always is poor, and not always. It is not always the same with these tumors. And for bladder cancer, there are a lot of possibilities of long-term survival, and the toxicity of the drugs are not as high as you may expect. So I think those are the big misconceptions of the patient. The toxicity is not as it used to be, and also the survival is improving. I think that's great things for the time coming. So I think the main point coming in the next years is the use of liquid biopsy to diagnose the patients. Liquid biopsy that can help to identify the right drug for the right patient. And not only that, the use of these drugs may identify progression earlier than the standard treatments. So not only that, the ctDNA and the liquid biopsy may help us to select patients for adjuvant trials. So selecting those patients that really have high risk of relapse in after a local therapy. So yeah, I think it's the most important thing in the near future. Absolutely. The success comes from a team, and the management of a bladder cancer and the management of prostate cancer is not the urology, the oncology, if not the team treating the bladder cancer. So good guidelines, good clinical practice, and multidisciplinary work together provide the best results. Most important point, it's first to a rapid approval of drugs that have proven that they show efficacy. That I think is one of the main points, rapid approvals. Second, to provide rapid diagnosis for patients to identify those patients that can still be cured with local therapies. And third, information. Patients should know what to do with if they have some urinary symptoms, etc., and where to go, and to identify those preliminary signs to go rapidly to the doctor. Yeah, there are gaps. We have checked that, we have analyzed that, and there are differences among countries. So yeah, still you have gaps, and not all approvals come directly to the patients. So yeah, absolutely, there's something that we have to fight against, and try to provide the right treatment for the right patient in all countries at the same time. Oh yeah, yeah. It's something we have to work together to introduce these drugs to all patients. That's the reason I was trying to explain. We have to select the right patient for the right drug, but at the same time, we have to improve the ratio cost efficacy for these drugs for each patient. I think in talking specifically about bladder cancers, one of the unmet medical needs is to preserve the bladder. So, and as we have better treatments with a higher complete remission rate, bladder preservation may be a target for more patients in the future. And I think it's something that we are going to fight for, trying to avoid some cystectomies that are quite psychologically not well accepted by patients. Yeah, within the urothelial cancer, I think the data for non-muscle invasive bladder cancer with the combination of BCG plus sansalimaab were the most exciting. What we could see, the standard of care in non-muscle invasive bladder cancer is BCG and maintenance BCG for 1 year. We have two problems with that. First, BCG has been there for 50 years and not being improved the results. And second, in some countries, we have a shortage of BCG. So we need new therapies to substitute BCG or to improve the data provided by BCG. And in the last ASCO meeting, a combination of sansalimaab, a PD-1 inhibitor, immunotherapy plus BCG, proved to better progression-free survival than BCG alone. So in the probably will become a standard of care in the near future.